Good evening, everybody. I am Josh Goodwin, the physician here at the clinic. So as you can see on the screen, hopefully, we're going to be talking about different knee treatment options that we provide here at Regenexx Las Vegas. Kind of the format of the webinar is going to be a little introduction into myself, a discussion about Regenexx, a discussion about, the common treatment options that are available for different knee conditions, some of which probably most of you guys are familiar with. And then we'll talk more specifically about some of the different things that we do. And then at the end, there will be a chance for some question and answer. You guys can chat down your questions in the webinar chat area. I may not stop to answer them throughout the webinar, but there is some time at the end. And then we'll have some contact information for everybody at the end if they have more questions, or if you've already been here before, you know how to get a hold of us. Again, this is more of a this specific webinar is more of a general overview of different knee treatment options. We do have some other ones that are for other conditions, and we'll have some more specific webinars in the future on very specific protocols that we have for different joints. So let's get into it a little bit more. For those of you that don't know me, again, my name is Josh Goodwin. I did go to medical school at the University of New Mexico. That's where I grew up in Albuquerque. I did complete my residency in a non-surgical field called physical medicine and rehabilitation. I did sports medicine and interventional spine fellowship. I am board certified. I've been with Regenexx since 2015. We'll learn that Regenexx has been around for about 20 years, and I've been with them. Next year will be my 10th year, and I am a co-author on some review articles discussing stem cell treatment for low back pain and disc degeneration. So as you know, we're here to just talk about the knee and different knee conditions. We're only going to talk about a few conditions, not all potential pain generators in the knee, but it is important to understand some of the different structures of the knee, and then understanding that helps us understand what the different issues and pain generators of the knee are. So we obviously have our bones that create the knee, our femur, our kneecap, the patella, and our tibia. Inside the knee, we also have shock absorbers called our meniscus. We have a medial lateral. We have internal supports, which are our ligaments. And we have external supports, which are our external collateral ligaments. Outside that, we have all of our muscular tissues and other connective tissue supports with our quadricep, other hamstring muscles that come around the knee, our tendons here on the front and the side, our iliotibial band as well. So these are all the support structures, the muscular support structures, the ligamentous, and then the actual bony anatomy. And within the joint, we have cartilage that lines the joint, which when that goes away is what we call knee arthritis. So we're going to talk about mainly just knee arthritis and meniscal tears. As we saw, all of those other structures of the knee can be injured in some way. So you can have ligament injuries, tendon injuries. There's bursas. You can have fractures. You can have nerves that get injured around the knee. All of these are also potential treatment options. The most common things we see related to the knee is knee arthritis and meniscal tears. So they're the most common. And so we'll spend most of the time talking about that. So what is knee osteoarthritis? So there's wear and tear. This can be accentuated by trauma. Over time, we start to lose tissue, as we can see here on the x-rays adjacent to the words here. We have a normal x-ray with good joint space, and we have an x-ray of the knee with lack of joint space. and that is what we call osteoarthritis. When we have cartilage breakdown, we can get a whole cascade of events that leads to inflammation, bone irritation, bony overgrowth, joint lining inflammation. You also can lose some of your stem cell reserve, and then that can allow the inability of your body to maintain the tissue. One important thing I think that people need to understand when we're thinking about knee joint degeneration and the osteoarthritic process is that it's not just a structural problem, it's also a chemical problem. Some of the chemicals that build up in arthritic joints are some of the things that advance and progress the degenerative and inflammatory process that can lead to, bone breakdown, joint lining inflammation, inhibition of muscle activity, those kind of things. And sometimes just addressing the chemical abnormalities can actually improve people's symptoms and joint preservation. And we'll learn that some of the procedures we perform are involved with not only trying to address structural changes, but also the chemical process. Again, most of us are aware of some of the current treatment options, which is going to include your over-the-counter medications, pain medications, steroid injections, gel injections, physical therapy and bracing, knee replacements, meniscal surgeries, those kind of things. We'll talk more about where some of the things we provide fit in, different options, these regenerative orthobiologic injection-based therapies and how they fit within this whole algorithm of treatment. When we're talking about knee arthritis, lifestyle can have a huge effect. If we're overweight, weight loss can help a lot. If we haven't been as active and we have weak muscles, that can help with pain and function. Modifying the activity, diet can play a huge role in total body and systemic inflammation. Smoking can affect our ability to heal and blood flow and those kind of things, and is not super helpful for healing. These are things that everybody to some level can implement in their overall treatment of their arthritic knee. There's also other supplements that can be beneficial. So glucosamine and chondroitin can be helpful, and there's some studies and meta-analysis that does show that it can help relieve pain and improve function and stiffness, equal to other non-steroidal anti-inflammatories with a lot less risk. Turmeric can also be helpful supplement for joint pain related to osteoarthritis of the knee. Physical therapy is often employed to try to help with function, range of motion, and strengthening. And we shouldn't take this for granted because even high-level athletes depend on therapy to help maintain function, and they're strong and they're always focusing on their bodies, and they're usually pretty strong, but they still can benefit from improvement of biomechanics or helpful if we're trying to look at stabilizing braces temporarily, if tissues are inflamed or injured, to allow healing to take place, and that can be helpful if we're trying to look at non-surgical options that can improve pain and function. Most of us are familiar with the non-steroidal anti-inflammatories, your ibuprofen and Aleve type medications. Just like anything we expose our bodies to, there's always risks that can come along with different options, specifically medications. So even these medications carry lots of risk, from stomach ulcers, cardiovascular risk like heart attacks and strokes, blood pressure issues, kidney dysfunction, and we're learning that they can even reduce our ability to heal if you take them in close proximity to an injury, and long-term use can actually increase joint pain. Often people are placed on more the stronger pain medications, which, as you all know, carry some risk as well, dependency and addiction, constipation, cognitive side effects. And the goal is obviously to not need medications or only need them sparingly, you know, for little joint flares or something, but not used on a chronic basis if we can avoid it. Other things that are often used to help treat osteoarthritic pain is cortisone. So this is a steroid-like medication, a corticosteroid, which is a strong anti-inflammatory. And while it can be significantly helpful for inflammation and pain, this comes at a cost. Cortisone is toxic to your cartilage and is associated with accelerated arthritic progression. It can weaken the bone, and we can get these areas that we call insufficiency fractures, where the bone has been weakened and it kind of fractures. It can lead to bone death called osteonecrosis. It increases the rate of knee replacement. And so while it can be helpful, it can come at a cost if it's utilized often and frequently over a given time period. So the best thing to do is to avoid cortisone injections if you can help it. Again, sometimes here and there is okay, and people can do okay, but the repetitive use can lead to complications. For example, in this article, it looked steroid injections increase the risk of requiring a knee replacement. So it just pushes you down that path a little bit faster. Same thing with hip injections as well. Really, for any joint or tendon injection, systemic therapy, any of that, it does carry some level of risk. Now, there are other injection options for knees that are FDA approved for knee arthritis, and that includes the gel injections, the hyaluronic acid injections, which are naturally a part of your joint, but you kind of lose the ability to create this as you get more advanced joint degeneration. And it can act as a lubricant and can help with pain and is healthy to the joint. It can be covered by insurance. It can be given every 6 months. And the only joint it is approved for is the knee. Traditionally, when all those other things fail, people might end up with a knee replacement. It's one of the most common joint replacements, with probably more than 700,000 to 800,000 of them performed annually. As we age, this number is going to go up significantly unless we can find other options. While it can be helpful for a lot of people, because it's more invasive, it's always going to carry more risk than less invasive options, right? And once you do it, you can't go back. So if you're one of the people that have complications, so 16% of people have complications, 2% can get infections, about 1% get blood clots, hardware loosening, about 20% of patients have chronic pain despite the knee replacement. Obviously, some people can get scarring, which can lead to more surgery. Not everybody gets back to full function. Obviously, full function, the definition of that can be varied depending on your baseline function and your goals. There is only one randomized study comparing knee replacement to physical therapy, and it took about 5 knee replacements to find one patient that reported more than 15% improvement compared to the physical therapy group. So while it can be helpful and it's a very successful procedure for a lot of people, it is not without some consideration, and it's important to understand these things when making decisions, right? It's about understanding the risk-benefit ratio, what's the chance for success versus complication. And as long as you understand all those things, then you can make the best informed decision. So a lot of this webinar is just to plant little seeds in your brain that you maybe never thought about when it comes to deciding on treatment options for your knee. We're going to move on to knee meniscal tears and just get some basic information about what the meniscus is and some of the more traditional treatment options. So there's the meniscus is those shock absorbers. Again, there's a medial and lateral meniscus. It's a type of cartilage, so it's a fibrocartilage. Some of the meniscus has blood supply and some of it doesn't. Some of that blood supply does decrease as we age and as we get degeneration. Now, what's important is not all meniscal tears are associated with pain or symptoms. So that's important because meniscal tears are often treated surgically. And we'll see here in a second that the success rates of meniscal surgery are not that great, specifically for degenerative type tears in the setting of knee arthritis. Now, typical treatment is typically physical therapy, maybe some bracing. Historically, just get a cortisone or a gel injection and do some modification. If those things fail, people have moved on to surgery. There's two different types of surgery. You can repair it, or you can remove or shave down or trim down the meniscus. It's always best to preserve the meniscus when possible. Historically, we've come a long way at meniscal surgeries, where historically they just used to take out the meniscus, thinking it wasn't that important for the knee. Now we know it's very important for knee preservation and function. Surgery is likely better for more mechanical symptoms and displaced tears where your knee is locking on you or getting stuck or caught, but it's not great for degenerative type tears, especially in the setting of some knee arthritis. Again, here's a study that showed 63% of people that had no knee pain had evidence of meniscal tearing on MRI. So meniscus pathology is very prevalent in 2/3 of patients, and none of these patients had any pain. So we can't get too caught up always in the setting of meniscal tears on an MRI because they're not typically a pain generator if you look at this study. Now, if we look at some surgical studies that looked at knee arthroscopy, so knee surgery for arthritic knees, is no better than fake surgery. So there's two groups, a group that got a clean out procedure and a group that just pretended to do that. There was no difference in the outcomes. Knee meniscal tears in middle-aged patients often don't cause pain. That's what we just saw. Arthroscopic knee surgery did not help patients with meniscal tears in the setting of mild to moderate arthritis. So the surgical group was equal to the physical therapy group, this randomized study. And then arthroscopic knee surgery for patients with degenerative meniscal tears, even without arthritis, does not do better than a pretend surgery. So it's not always the right thing to do to get meniscal surgery. And why would you want to avoid meniscal surgery? Again, maybe it's not the cause of pain. And if you do get it, we know that it increases the rate of osteoarthritis and increases the rate significantly for future knee replacement. So what else is there to consider and to think about? And that's where we come in. So the Regenexx approach is essentially joint preservation. What can we do to help you keep your joint, keep your tissue, avoid resection, avoid removal, avoid replacement when we can? Again, it's not always possible, and we understand that. Now, Regenexx has been around for 20 years. We do have a research and development team in our Colorado clinic. They've been around for 20 years. We've always done clinical research. We always have laboratory studies, patents on lab processing. We have a large registry where we're tracking 90,000 patients. Roughly 20,000 of them are for knees. All this information helps us guide treatment decisions, and we publish research. We do have a knee osteoarthritis study that was published, randomized against physical therapy, showing significant improvement in knee outcomes as opposed to physical therapy for knee osteoarthritis. We also have some for ACL tears. Like I said, this slide's a little bit older. We have about 90,000 patients in our registry, and we're about 20,000 patients with knee conditions. So that's really helpful for us to help try to guide decisions. And it's always important for when you guys are seeking out different options to just ask questions about these different things like success rates. Do you track patient outcomes? Now, everything we're doing is just the evolution of medicine and trying to find ways to take more invasive surgeries like meniscal resections and knee replacements and see if we can replace and preserve tissue so that we can avoid those more invasive options. And we call this interventional orthopedics, right? So we're using needles. We're going to use things like stem cells, platelets, or growth factors, and we're going to deliver these into tissues that are degenerative, injured, or inflamed, with the goal to help improve the localized healing process, inflammation, reduction, restoring that chemical environment, like I talked about with knee arthritis. And because it's less invasive, it's always going to come with less risk. It's important to understand the full function of the knee and other contributing factors, like if someone has a pinched nerve in the back, sometimes that can create knee pain if it's the L4 level. So we have to make sure that the knee is the actual cause of pain. And maybe in those knee replacement studies where 20% of people still have pain, maybe it wasn't the knee as the main generator of pain in those patients. It's hard to say, but understanding the totality of the problem is very helpful. We have to remember the knee is a functional unit and all of these structures work together. So when we get joint loss, the ligament can be affected as well and can become loose. If we get inactivity because of pain, the muscles and the tendons can become affected as well. So it's important to look at the knee as a global unit as opposed to just individual structures as well. So what are some of the different treatment options that we utilize here for knee arthritis and meniscal tears? One of them is called PRP, A2M, and bone marrow concentrate, which contains mesenchymal stem cell. This is our stem cell procedure. Now we have to understand that our bodies do have the capacity to heal, even from surgery. The surgery is going in and manipulating tissue or replacing it, but you still have to heal from the surgery, right? So we do have mechanisms by which we can heal. We break bones, our bones heal. We cut ourselves, skin heals. I ruptured my Achilles tendon when I was 17. I never got surgery, it healed. So we do have the capacity to heal. We have cells like we talked about, platelets, we have growth factors, and we have stem cells that are all involved with that process of healing. And these are the cells that we can take advantage of in degenerative joints or injured joints to help improve the healing process. So when we're talking about PRP, we're talking about platelets. Platelets do have many functions in the body. They help with clotting, and they are also the activators of healing. And the signals for healing come from these different growth factors that get released in the environment. So growth factors for cell growth, tissue repair, collagen production, new blood vessel growth into an area to help increase the network of blood flow to a region. And so we could take advantage of these different healing properties, and we tend to use them for mild to moderate arthritis, small meniscal tears, tendonitis, bursitis, tendon issues, ligament strains and sprains. And these can help, again, create a better chemical microenvironment in the knee. It can reduce those destructive arthritic chemicals and directly stimulate the tissue for strengthening and improvement. A2M is a growth factor that can be isolated from the blood. It's a strong anti-inflammatory, and it is involved with reducing swelling, reducing cartilage breakdown. This works more on the chemical environment, like we talked about, arthritis being more of a structural and chemical problem. And this can take care of one of those problems by getting rid of those destructive inflammatory chemicals and reducing those, that allows some preservation and tissue maintenance and can be very effective at improving pain when it's related to those elevated inflammatory chemicals and cartilage breakdown enzymes in the knee. And what people hear a lot about are these mesenchymal stem cells. These are found within our bone marrow concentrate, which we do take from the bone marrow. Now, stem cells are unique in the sense that, at least in the lab, they have the ability to transform into different cell types, including cartilage cells. And so we tend to use these because of their ability to respond more to the environment, help restore that chemical microenvironment of the knee to a more healthy state. And we use it more for the moderate to severe changes, larger tears, or if you just didn't get enough improvement out of other treatment options, including PRP, then we might utilize this as an option to help improve bone health, joint health, tendon, meniscal tissue as well. So a little summary of the different things that we perform here as other options and other tools in our tool belt outside everything we already talked about, like the medications, cortisone, gel, surgery. These are additional tools to help with the joint preservation. PRP, again, mild to moderate arthritis, small meniscal tears and ligament injuries. A2M for joints that have a lot of arthritic swelling, or bone marrow concentrate, which contains those mesenchymal stem cells for more severe issues or for those bony injuries that often come along with more severe arthritic change, which we'll talk a little bit about as well. So is there data to show that knee arthritis and meniscal issues can be improved with PRP? So here's a whole list of randomized controlled studies. I do have an updated link for up to 2024 now, which includes a lot more studies. But this is for knee arthritis, showing that PRP was more effective than gel, medications, saline, steroid, in all of these different studies. There's also a recent study showing PRP is more effective than knee arthroscopy, those clean out procedures for knee osteoarthritis. Other studies for the knee with bone marrow derived stem cells, a lot of studies looking at these cells for knee osteoarthritis and other conditions like meniscal tears, ACL tears, as well as bone injuries. So again, we did, as an organization, the Colorado Clinic did publish a randomized controlled study utilizing the bone marrow derived stem cells and PRP versus physical therapy for knee osteoarthritis with 2-year follow-up, where PRP and the stem cell process was more effective for improving knee osteoarthritic pain at that 2-year follow-up. Another study, which was about a 15-year-long study, which showed that utilizing bone marrow derived stem cells through bone marrow concentrate injected into the bones of the knee, 80% of people were still good at 15-year follow-up. This specific study was compared to joint injection versus bone injection. So injecting the bones of the knee was more effective than injecting just the joint. There is another similar study comparing bone stem cell injection with knee replacement, showing a similar conversion rate. So all in all, there was a relatively good long-term outcome in the patients that had their own bone marrow derived cells injected into the knee and the corresponding arthritic bones. There's some studies on the alpha-2 macroglobulin injections for knee osteoarthritis. A2M in this study was actually more effective at reducing arthritic symptoms than PRP and steroid injections, although the PRP in the study was kind of lower dose. And we don't talk too much about it, but PRP and a lot of these different injectable options are dose dependent. So it's really important to make sure that someone's getting dosed properly. And if people have more questions on that, we can kind of talk more about that. So we know that not everybody's a good candidate for PRP or bone marrow or A2M type injections or treatment. And so you have to have an evaluation process to explore if people are a good candidate or not. And we do that here in our clinic here with a long consultation, reviewing of your medical history and imaging, which could include ultrasound, X-ray, and/or MRI. MRI is very effective at looking at all the tissues. Physical exam is important, as I mentioned earlier, to make sure there's no other issues creating the knee, like a pinched nerve in the back or some other soft tissue referral pattern. And this is how we decide the candidacy: high, moderate, or low responders. And most joints have their own, candidacy grading, but it's determined by what we see on exam and imaging. If someone was going to get a PRP procedure, it's a one-day procedure that has two parts to it. We have a blood draw and injection part. In between is the processing. Now, this is where it's important to have flexibility. Not all PRP is the same. There's different types of PRP. There's high concentrations and low concentrations. Some of the studies that showed PRP was not as effective for example, knee arthritis, were in low dose PRP products. And so we know that as we age, our tissues respond better to higher concentrations. And so having a flexible lab platform like we have allows us to customize the concentration and type of PRP based on age, injury severity, location, and tissue type. And then when you're getting an injection with PRP or stem cells or other products, it's very important to use image guidance. There are studies that show that even seasoned orthopedic surgeons miss the joint often compared to ultrasound guidance, which you'll get into 100%. But even orthopedic surgeons can miss the knee joint when you're trying to inject some of these solutions in some randomized studies. And so you want to make sure that if you're getting treated by someone, that they're using image guidance, because it's important to get them in the right locations. A2M is also a one-day procedure from a blood draw. Processing is a little bit longer. And again, we do the injection guided. Stem cells can be from the bone marrow, can be a three-step process, depending on the severity of what we're treating. In the three-step process, we do something called prolotherapy. That helps stimulate the healing process and the recruitment to the joint, followed by the bone marrow derived cells 2 days later. And then we do kind of do a post-injection about 3 to 7 days later with PRP, which is kind of a fertilizer for the cells that were placed there previously. Not everybody needs a three-step process, but this is one that we have researched and a lot of what our studies show to show the benefit. This is what I was just talking about with the three-step bone marrow-derived stem cell process with the pre-injection with prolotherapy, the bone marrow aspiration and processing and injection, and the PRP post-injection. Now, most people are very nervous about the bone marrow aspiration. We do have IV sedation available. Everybody gets local anesthesia. 9 out of 10 patients rate the discomfort, even when they're fully awake, on the 2 out of 10 scale, so more mild. Obviously, some people have different experiences. If you numb the tissue up a lot, you can do pretty well without significant discomfort. And as I was mentioning, image guidance is important. So when you're using ultrasound, you can see the needle in the knee joint. And so you're 100% confident that you're getting the cells into the location that you need them. Or you can use X-ray to show needle placement and a little contrast to ensure you're getting the cells where you need them. Now, this is a higher level procedure over here where the bone's also getting injected because of a bony injury. Not everybody needs that, but again, image guidance, this is just showing you that image guidance can be very helpful in precisely placing and seeing what you're injecting and where. If you're injecting the meniscus, this is an ultrasound of the medial meniscus right here, and the needle coming in to inject along the ligament and meniscal ligaments. This is an ultrasound dissecting the fat pad away from the patellar tendon, which can be helpful in patellar tendonitis, or injecting into an injured tendon of the knee where people have tears or degeneration. And again, it just shows you that you're getting these cells into the right location. Or if you have a bony injury associated with the arthritic change, you can see injecting the cartilage surface as well as the bone associated where the arthritis is to help strengthen the bone and the joint surface itself. You got to use image guidance to ensure you're in the right locations and you're injecting the right tissue. Now, post-procedure, depending on what we're doing, most people are going to have a couple days of increased pain. Most people will need some level of physical therapy, depending on their biomechanical status. Some people will need a knee brace. Now, again, a lot of these are just kind of the averages. Not everybody needs knee bracing. Not everybody needs physical therapy. It kind of just depends on where they are functionally. We do prescribe some pain medications after because we want people to be off their anti-inflammatories for a couple weeks. On average, for the first 2 weeks, we recommend low impact exercise with a slow return to full activity over that first month or two, depending on how you're feeling. If you're doing bone injections, large tears, big ACL tears, you might need more restriction for a longer period of time. And at a minimum, we follow up at least 4 times in the first year, sometimes more if there's more symptoms we need to follow up on. Some people will need more than one treatment over time. Just depends on, everybody's different, right? Not everybody's going to respond the same, even with the same pathology. We've learned that there's a lot of variation between individuals. We don't know how to measure that difference all the time and why one person might respond a little bit better or faster than the next person. But you have to have close follow-up to ensure people are getting better. And that's part of the overall process as well, is that proper follow-up. So again, that was just more of a brief overview of some of the things that we do, trying to plant the seed in helping people be more aware of some of the different treatment options, being aware of some of the risks and benefits of even very simple things like taking an ibuprofen, and some of the considerations when you're removing tissue like meniscus, and the fact that even a joint replacement isn't always a cure for everybody, given that there's a lifespan to that joint. 20% of people still have pain. And because it's more invasive, you open the door for all the potential complications. Now, again, sometimes it's the right choice. And we try to help people along with that choice. We send people to get knee replacements if we don't feel we can help and that's the right option. But it's also good to understand, is there a way to preserve the tissue, to treat tissue early, strengthen it, improve that chemical environment, along with maybe some activity modification to allow someone to have less pain and more function. So if people do have a desire to want to contact us and get scheduled for a consultation, and you haven't been here already, you can contact Danielle at our patient education and scheduling team. Her email is here, the phone number is here. She's a good resource to get you information or to translate information to me, or just to get you on the schedule for consultation. We did have a question emailed earlier about recovery and post-procedure expectations. So in general, with PRP, for example, if we're just treating an arthritic joint and not a huge meniscal tear, there's about 2 days where your joint feels stiff. And so you're going to modify your activity to just flat ground walking, range of motion, and nothing high impact. Over the first 2 weeks, you'll probably stay with a little more low impact activity, flat ground walking, getting on a bike, elliptical, getting in the pool, continued range of motion, stretching, mobility. And then after that, you're going to just progress in your activity as you're able to. Again, if you had a large displaced meniscal tear, an ACL tear that needs to be protected, then it's going to be more restricted. If we have to inject a bone injury along with your joint, then some people will need a crutch for 2 to 3 days and a brace, and weight bearing as tolerated, and then you'll improve. As you feel better, you'll be able to do more. Hopefully that answers the question. Let's see. So a question, with the shoulder being a small joint and muscle area, would PRP be recommended for low concentration or high concentration? It's not so much the size of the joint that is going to affect the concentration of the joint. It's more the severity of what's going on and the age of the patient. So we might do a similar concentration in your thumb joint. Now the volume will be different, obviously. So your thumb joint can accommodate 1 cc, and your knee joint can accommodate way more. We usually inject about 5 or 6, depending on what we're treating. So the total platelet delivery will be different. But if you're, in the 50 or above range, we're going to go in the 14 to 20 time concentration. If someone's in their 20s or 30s, we might be in the 5 to 10 times concentration for a joint. Soft tissue, we tend to go a little bit lower concentration unless the degeneration is more severe. But you might put the same concentration in the shoulder as you would the knee or the hip. So it's not so much the size of the joint, it's more the age and the severity, and then what specific structure you're actually treating. Any other questions that people have? The overall safety, some people ask about, we talked about, I'll ask this, it says, will your treatments work on bone knee issues? So it's definitely possible to have some improvement in bone-on-bone joints. We've treated a lot of people with bone-on-bone. Now, even with bone-on-bone, there's a variation. You can have a focal bone-on-bone on just the inside compartment of a centimeter, and you can have diffuse bone-on-bone. Those are 2 different scenarios. So there's a lot of different factors. Is it more focal? Is it more widespread? And then what's the baseline knee function? And what does the bone health look like? Which MRI is important. As I was saying earlier, there's some studies that looked at bone-on-bone patients and treating the knee bones with bone marrow derived cells, with 80% of people maintaining pain and functional improvement over 15 years. There was a 20% conversion to knee replacement at some point over that time. And these were all knee replacement candidates to begin with. So yes, it's definitely possible. But then there's these little nuances and things that we look at on exam and with imaging to decide if that would still be a good option or not. It says, do you use the hyperbaric chamber therapy? Yes, we do have a hyperbaric oxygen chamber here in the clinic. We've had it for maybe 6 months now. You definitely can use it pre and post for trying to accelerate the healing process. It's maybe not the best treatment in isolation for knee arthritis or meniscal pathology, as it's kind of helps system-wide, although it can help with inflammation. It can help improve oxygen delivery throughout your body to help with healing. But yes, we do have a hyperbaric oxygen chamber in the clinic. It is a hard chamber. Let me see. I don't know if I have some. Let's see if I had some pictures of it. But yes, we do have that here in the office, and it can be combined with treatment as a way to kind of accentuate and accelerate the healing process post-treatment, help with post-procedure inflammation, tissue healing, oxygen delivery can be very helpful. And sometimes even doing like a pre-optimization before, say, a bone marrow extraction can also be helpful as well. Forget what I was going to say before that. But yeah, safety. We did do a 10-year safety study that looked at 2,300 patients, and the overall complication rate was 0.17. So that was compared to your 16% complication rate from knee replacements. And most of the complications were increased pain, swelling, bruising, maybe some focal nerve irritation, things like that. So now, obviously, anytime you're poking people's joints with even a small needle, there's always a risk for infection and these complications. We just don't see them really happen all that much. So again, because it's less invasive, then the overall potential for complications is going to be a lot lower. Well, I don't see a lot of other questions at the moment. Again, here's the contact information for our education and scheduling team. If you've already been to the clinic, obviously you can come back and see us. You know how to get a hold of us. Okay, thank you. Yeah, we'd love to see your brother-in-law, take a look at the knee, see if we can help. So reach out to us. Hopefully there was some new information for you guys that you can take and digest and think about. And if you're having some knee issues, we'd love to see you in the clinic to see if we have any options for you. Thank you all. Have a good evening.